I'm going to talk about the implications for palliative care because that's obviously relevant to all of us. Now, you may sometimes feel that uh, with regards to assisted dying, we're sort of living on a knife edge here. If you do feel that way, welcome to the club. Now, you need to know my starting point. I'm an agnostic. I am a convert. I have to declare interest. I'm a palliative medicine doctor. Why do I have to declare it? Well, over three quarters of palliative medicine doctors are either against or very skeptical about assisted dying. I also have to be honest and say that my brain, as you get older, is a bit like Swiss cheese. It's firm enough to stand on, but it's full of holes. And I've spent my life filling those holes, and I'm still filling them. So I have lots of questions whenever I meet a particular issue. And and yet it would seem really that assisted dying is self-evident. I mean, it's about individual autonomy. Can't argue with that. It's about choice. You can't argue with that. We're told that it reflects reality, it's widely supported, and it's already happening now in an illegal way without safeguards. So, what is there to be arguing about? It's about choice, it's peaceful, it's quick, protection, safe. These are all words that are used. So why am I fussing about this? Well, I perhaps need to explain. First, I need to start with some definitions. These are NHS definitions, by the way. Assisted dying is a generic term, and it has two components. One is assisted suicide. That's providing the means for a patient to end their life. That's prescribing and providing medication. By the way, a court of law, in theory, can do that. The patient must take the medication themselves. The other aspect, the other part of assisted dying is euthanasia. That's where medication is administered by another person, usually a doctor, but often another individual, can be a nurse, to end the life of a patient. Now, neither of these are legal currently in the UK or in the Crown dependencies. I should add that the current proposals throughout the UK are about physician-assisted suicide and physician-assisted euthanasia. In other words, the current proposals embed assisted dying within healthcare. This is very different to stopping or withdrawing treatment. That's a decision by a patient with capacity to stop treatment, or following best interest decision in a patient who lacks capacity to have their treatment stopped, even if that would mean the death of the patient. Now, people often conflate assisted dying with this, but this is currently possible, and what's more, is legally protected. We'll see why it's important later. So what's the current situation? Well, to date, there have been 5 Westminster assisted dying bills. They've all failed so far. There was a Westminster Hall debate on the 28th of April. Interesting enough, surprisingly balanced. There were some very strange things said, but there was a balance of views. Jersey and the Isle of Man are currently in the process of passing both physician-assisted suicide and physician-assisted euthanasia bills. Scotland has submitted a physician-assisted suicide bill. They're not currently thinking about euthanasia. Aware that Labour, the Liberal Democrats, and the Greens all support assisted dying. Really, this is not so much a question of whether society should legalize assisted dying, but actually this in the end is a decision for societies through their own parliaments. It's not our responsibility. However, it is our responsibility to decide and have an opinion on what our role should be if it is legalized. Okay, now, where do doctors sit on this? Well, palliative medicine is an outlier in many ways. As I say, over 3/4 are either skeptical or against the concept of assisted dying, but we're in good company. Geriatric medicine, renal medicine, clinical oncology, gastroenterology, medical oncology, rheumatology, endocrinology, and general practice. Now, that general practice is important because it has been assumed that both general practice and palliative medicine would do this. So there is an issue about where doctors sit. Now, back in the BMA survey a few years ago, there was a small majority in favor of legalizing assisted suicide. But it's interesting that when they were asked the question, but would you actually do it? There was a majority against. In other words, There are doctors out there who say, oh, yes, I think it's a good idea, but don't ask me to do it. When it came to euthanasia, there was a majority against legalizing that, and an even bigger majority unwilling to prescribe. And it is interesting, when it actually happens, the percentage of doctors who actually prescribe is incredibly small. Only 2% of doctors in Canada and Oregon prescribe assisted dying drugs. It's said to be less than 1% in Australia. And the result is that, interesting enough, a very tiny few, do the majority. So most doctors only prescribe once or twice a year. Would you go to a surgeon that only does that particular procedure once or twice a year? Interesting, isn't it? Now, it's been said that palliative medicine doctors have been rebutted or stifled, suppressed from airing this topic. So a few years after this statement was made, the Association of Palliative Medicine did a survey, and just under a quarter of doctors responded. Less than 1% believe their employer supported assisted dying. So 29% knew that their employer was opposed to assisted dying. 60%, that's quite good, it would be nice if it was more, were able to discuss assisted dying openly, but nearly a third hadn't experienced that open discussion. 10% said their organization had or would inhibit them from speaking out. And the usual reason given was that they were worried that this would affect fundraising. It wasn't because of some ethical or moral issue. 11% felt their organization actively encouraged staff to speak out, which is good. What is very interesting, because it's pertinent later on, is 2/3 said patients and families think we already do it. So taking that further, what do the public understand by assisted dying? This poll was interesting because nearly half of the public consulted thought that assisted dying was about stopping life-sustaining treatment. Something that I explained is already possible, is already legally permissible, and what's more, legally protected. 10% thought it's what you do. Only 43% recognized it was about giving lethal drugs. So we have this question mark about this popular support as to whether actually people really do understand what is entailed. And we have a problem in the current debate. A lot of it is based on emotions, understandable. It's largely devoid of facts. There's a lot of misinformation, misdirection, and selective data selection, probably on both sides, but some more than others. And the reality is that you can tell people about 1,000 of your good deaths. It'll only take one bad death to completely ruin that. And that's an issue. Remember, Brexit had Project Fear. It's working very well when it comes to assisted dying. And when you've got a large amount of finance behind it, Dignity Dying and other groups are very good at what they do. They're very professional and they have the money to do it. So what sort of claims have they been making? Well, these are all recent claims. The side effects of opioids can be very unpleasant. Can you imagine one of your patients walks in with pain and you say, yeah, but the side effects of opioid, yeah. Death presents people with a paralyzing fear, Project Fear. Persistent 24-hour nausea that cannot be treated because of allergies to antiemetics, a problem I'm sure you recognize every day. You start to realize there's some very strange things being told out there. 17 a day die in pain. I'll come back to that one. And opioids hasten death. Paracetamol and insulin have much narrower therapeutic margins, much more likely to kill somebody with that. Opioids have this very wide therapeutic margin, and yet this is being promoted as a reason for saying, look, this already happens. Now, because of my Swiss cheese brain, I'm perplexed about lots of things. Let's start with the first one, missing data. In the Isle of Man and in the Westminster Hall debate, people were saying, there's all these jurisdictions, let's learn from them. Well, we'd love to, But Canada, Belgium, Switzerland, and the Netherlands publish little or no data. Dignitas publish nothing. And I don't know if you're aware, but there isn't a single jurisdiction that monitors the decision before the death. Some of them will review a small percentage after the death. And guess who's the professional witness? The doctor who did it. Would you allow that in any other healthcare situation? Now, Oregon provide the most detailed data and most regular data. They've produced 26 years worth of data now. But they destroy all their source documents 1 year after each annual report. And what's more, data on complications, for example, is missing in 3/4 of patients. We have no idea. We've got the data on a quarter, so we've got a sample, but it is only a sample. So there's huge amounts of missing data, and there's loads more missing data in the Oregon data. What about palliative care? We hear this all the time. Well, in other jurisdictions, the law changed to assisted dying and improvements to palliative care have gone hand in hand. So what's the reality? Unfortunately, neither the Health and Social Care Committee nor the speakers at the Westminster Hall debate even bothered to look at this paper, which has nothing to do with assisted dying. It was a paper which looked at the growth of palliative care services in Western Europe. And what was interesting is that they looked at the number of services per 100,000 population. So it looked at whether jurisdictions were meeting need. So a really important paper. And yes, services had grown their palliative care services, but non-assisted dying countries had grown faster. What's more, Dutch and Belgian palliative care growth had stalled since 2012. There's been no growth at all. And the need has carried on climbing. And just last year, New South Wales and Australia announced that they were going to increase their assisted dying funding, but they were going to reduce their palliative care funding. So you can understand that my skeptical Swiss cheese mind says, is this fact really true? That palliative care and assisted dying go hand in hand? Because that doesn't seem to be what's happening. So what about hospices? Well, it's interesting in Oregon. I mean, that's been going for a long time. In 2012, 2/3 of hospices actually refused to take part in assisted suicide because they have assisted suicide there. They actually had policies which prevented their staff from going out, for example, into people's homes and to accompany an assisted suicide. We haven't got recent data, unfortunately, so we don't know whether that's changed at all. In New Zealand, there is one hospice that's agreed to take part, but none of the others agreed. And in fact, because they were so anxious about what would happen, they went to the High Court to obtain authority to refuse. What they didn't get was permission that would not be affect their government funding. So it is possible that governments in the future may actually push New Zealand hospices to have assisted dying. And that's important because in Canada, Belgium, and New South Wales, no health organization can opt out. Simply not allowed. And in Canada, one hospice has been taken over by the health authority. The charity were just thrown out, and the health authority took over. So hospices some parts of the world are being faced, who have always cared for the living until death, are now being faced with a new choice of providing death. So what about access to palliative care? We're told that all these assisted dying patients have had access to palliative care. Well, not really. In one survey, one review, looking at 23 countries, palliative care involvement was less than 19 days for cancer and 6 days for non-cancer. Less than half of Canadian assisted dying patients, MAID patients, medical assistance in dying, less than half had seen a specialist palliative care team. And it's very important. A lot of people claim that people have had palliative care. What they're talking about, when you actually look at the questions and the stories, they've had no specialist palliative care whatsoever. They've had a GP who's visited once and prescribed some opioids, or a single nurse that came in. So we need to separate general end-of-life care from specialist palliative care. In Australia, over half of dying hospital patients were never referred to a specialist palliative care team. And in the UK in 2017, there's been no estimate since, But in that year, Hospice UK estimated that 118,000 people who needed specialist palliative care couldn't access that care. That's over 300 a day. And do you remember the claim that 17 a day get pain? I'm not surprised. There's 300 a day who can't access palliative care. No wonder. Okay, any other care option, you'd be looking at its efficacy and safety, wouldn't you? And you know what? It's pretty effective. I mean, assisted suicide is 98% effective. Euthanasia, 99% effective. That's pretty good. But you see, this study is 24 years old when it was published, and it used data that was 10 years old. So this is from data that is 34 years old, never been repeated. No prospective studies. But is death the only endpoint? Clearly, it's about the journey leading to the death, and people aren't looking at that with assisted dying. So, do they look at complications? Well, yes, Oregon is the only one that provides some data. And remember, it's oral drugs. We don't know quite what the situation is with intravenous drugs. But on average, there's a 9% complication rate. I mean, it's nearly 1 in 10. Difficulty swallowing, vomiting. Time from ingestion to death is 2 minutes to 24 hours. It has been much longer than that. Over half take 54 minutes or longer to die. That's important because you notice one of the words in the word chart was quick. Well, it's not always quick. We have a report from Washington that's very similar to Oregon. In their 2020 report, also using oral drugs, they found that 16% took more than 2 hours to die. What's interesting is that their subsequent reports have not included that statistic. I think people spotted it, made a fuss about it, and they didn't put it in next time. Oregon have tried 4 different drug mixtures, cocktails, if you like, of 4 to 5 different drugs. People think it's about one drug. It's not. They've tried 4 different ones in the last 8 years. They've admitted that's resulted in more prolonged deaths. But that trial of drugs is not being done with research safeguards. There are no patient safeguards. This is experimentation. It wouldn't be allowed in any other situation. So what sort of mixtures are there? Huge number. Sedatives, analgesics, cardiotoxic agents, antiemetics, and in intravenous, neuromuscular blockers. I haven't put the actual drugs here, apart from 1 or 2. Analgesics actually feature very little. And in intravenous use, they don't feature at all very often, which is odd because if we're killing our patients with opioids, you'd think that they would be primary drugs in lethal drugs, and they're not. Now, what's interesting about these drugs is the doses they use are 25 to 300 times the therapeutic dose. So this is really off the scale. And campaigners say, look, it's not a problem. We're going to use these drugs because they've all been approved for one reason or another at therapeutic doses. They say, well, we're going to use them off-label. That's a little like saying, well, 2 tablets of paracetamol has been approved, so it's okay to give somebody 600 tablets. Clearly, this is a nonsense, but that's what they're trying. And it may not surprise you that there isn't a single drug regulatory authority anywhere in the world that has approved assisted dying drugs or doses. So it'd be interesting to see how the UK copes with that. So how effective is it? Is it as good? Is an assisted death more peaceful, calmer than a non-assisted one? Well, this was a paper that compared the characteristics of Dutch MS patients receiving PAS with those dying without intervention. It was a survey of physicians. Home death was more likely, but then they tend to die more likely at home at an earlier stage. They were less anxious. Well, they knew what they were going for, but the death was just as peaceful. There was a better study looking at Oregon families, and they were interviewed, and they rated their experience using a validated quality of dying questionnaire. AS patients had better symptom control, but then they died earlier. Were better prepared for death. Well, okay, but that's what they were asking for, so that's not a surprise. But there was no difference in the remaining 24 quality indicators. These are the only 2 studies comparing assisted deaths with non-assisted deaths. It's remarkable that we're going to change the law for a care option that has only 2 studies. So what about suicide? Well, we're told that suicide rates would drop. The orange line is Montana, the red line is Oregon, blue is Washington. The green line is all other US states. So these other states have much higher non-assisted suicide rates. And you can see that they go up and they tend to climb. And we've looked at the latest data, and legalizing assisted dying definitely does not reduce non-assisted dying suicide rates. And some have actually seen an increase. Oregon has seen a 30% increase. And women are more likely to be placed at risk of premature death. That's a red flag, it should be. So what about safeguards? Well, Canada no longer requires a terminal diagnosis. You can be frail and elderly. The cooling off period in California has been reduced from 15 days to 48 hours. Oregon have entirely removed their waiting period for a fifth of their patients. And assisted dying is available for anorexia. So if you're a 16-year-old in Scotland, 18-year-old in England and Wales, and you said, I'm not eating anything more now, and you're already severely anorexic, you're going to die within 6 months. And if you have capacity, you're eligible. And in time, every safeguard is viewed as a barrier and discriminatory. And My Death, My Decision are already campaigning to remove any time limits, not mind the 6-month limit. And there was an interesting paper in 2019 from the Dutch Euthanasia Clinic, the expert euthanasia clinic. The commonest diagnosis was a depressive mood disorder. This was people who were with psychiatric or psychological issues that were requesting an assisted suicide or euthanasia. They didn't all get it. But the depressive mood disorder should be a red flag. The fact that they were more likely to be single, female, low educational background, and with a history of sexual abuse should also be a red flag. Nothing happened as a result of it in the Netherlands. So what about the law? How good are we at safeguarding? Mental Capacity Act, best safeguarding legislation for generations. How good are we at doing that? Well, we still have repeated episodes of abuse. We've had a pandemic which exposed discriminatory decision making. We're not doing very well. And they say, well, it happens already and it's going to reduce illegality. Yeah, well, in Belgium, nearly half of assisted deaths are never reported. In other words, they're illegal. Oh, in the fifth nearly, it's because of the administrative load. In Netherlands, it's 20%, not reported. So these are all illegal. So when people say you're going to reduce illegality, actually it goes up. Canada, we have no idea what goes on with adherence to the law. They're just not recording this. In Belgium, we do, but they agree that the law is not being followed. So what about money? Well, Canada saved a lot of money in 2021, nearly 100 million equivalent pounds. One assisted death costs the equivalent of £1,500. That's the equivalent of 2 weeks nursing home care. It's cheap. Assisted dying is very cheap. So is assisted dying a possible source of revenue for hospices? Well, I can understand why people want to look at that. Can I remind you of this headline with the Liverpool Care Pathway? Do you want a headline that says hospice care being bribed to kill patients? Because, Mail Online would love that, wouldn't they? And that's what we were accused of with the Liverpool Care Pathway, which eventually disappeared, of course. So what about us as doctors? Well, we're not trained to detect coercion, manipulation. We're poor detecting depression, capacity we sometimes struggle with. We don't have a tool for estimating suffering. We're not good at estimating prognoses, especially non-cancer. Half of cardiac prognoses are wrong. So we're biased and fallible actually because of the compassion we're showing. The same applies to nurses. That actually creates a huge bias on our part. And doctors are the weak link in deciding on assisted dying. So all these proposals to embed it in healthcare and have doctors, I think is very worrying. And also there's an impact. Participating in assisted death has a psychological impact in up to half of doctors, and that persists long-term in a fifth. And the factors that contribute to the emotional burden are discomfort with the process, the difficulty about assessing capacity, judging if the patient fits criteria, and the fear of psychological repercussions. People are really frightened about the impact it'll have on them psychologically. So let's finish up with this. Let's say it's been legalized. So it's been legalized. First thing you have to do is having assisted dying on site going to reinforce the belief that everybody dies there? Would it become a criterion for selection? Are you only going to select people who actually agree with it? And could it actually result in constructive dismissal? That's an issue. Have you got enough HR and counselling to support the staff who decide to take part? Who's going to do the governance, the training, sort out the insurance, and who's going to communicate with the public? Who's going to be responsible for assessing capacity, excluding manipulation, reversible depression or anxiety? Who's going to do the documentation, arrange with independent doctors, and liaise whichever authority deals with it? Are you, as doctors, willing to prescribe unlicensed lethal drugs? Is the pharmacy, you've got a pharmacy who's going to dispense them? You've got somebody who's going to prepare them, can be up to 100 capsules to put together. Where are you going to do the death? Who checks the patient hasn't changed their mind? Who's going to be present? And what about the process? What are you going to do if the patient vomits, aspirates, or has a seizure? What if the death takes hours or days, or doesn't die at all? What are you going to say to the other patients? What additional staff do you need to assure that the care of other patients isn't jeopardized? If you think this doesn't take long, doctors in Australia have estimated 60 hours. Are you going to allow staff to attend an assisted death at home? You're going to provide indemnity for that? So if you want more information, you can go onto this site, CADO, kadoh.uk. There's lots of evidence on that, and you're welcome to look that up. Thank you for listening.